Welcome back to Audioboards. Today we're covering hyperthermia management, one of the most important and time-sensitive emergencies you'll encounter in medicine. Hyperthermia is one of those conditions where delays in recognition and treatment can rapidly lead to neurologic injury, multi-organ failure, and death, so it's worth having a systematic approach.
Before we get into management, I think one of the biggest points of confusion is the difference between fever and hyperthermia.
Absolutely, and that's where we have to start because everything else builds from this distinction. Fever is a regulated physiologic response. The hypothalamus intentionally raises the body's temperature set point, usually in response to infection or inflammation. The body then actively works to reach that higher temperature through mechanisms like vasoconstriction and shivering. Hyperthermia is completely different. In hyperthermia, the hypothalamic set point remains normal. The body isn't trying to become hotter. Instead, heat production exceeds heat dissipation, or thermoregulatory mechanisms fail entirely. As a result, body temperature rises in an uncontrolled fashion. This distinction is critical because antipyretic medications such as acetaminophen and ibuprofen work by lowering the hypothalamic set point. They can help with fever, but they have essentially no role in true hyperthermia. A common teaching point is that giving acetaminophen to a patient with heat stroke is like trying to put out a house fire by adjusting the thermostat. The problem isn't the thermostat, the problem is uncontrolled heat accumulation.
And that's why cooling becomes the cornerstone of treatment?
Exactly. Hypothermia is fundamentally a cooling problem. Once temperatures start climbing above about 40 degrees Celsius, direct cellular injury begins to occur. Proteins denature, cell membranes become unstable, inflammatory cytokines are released, mitochondrial dysfunction develops, coagulation pathways become activated, and widespread tissue injury follows. The physiology starts to resemble severe sepsis. Endothelial injury occurs, capillary leak develops, microvascular dysfunction worsens, and multiple organs become vulnerable to injury. One important concept that shows up repeatedly in the literature is that both the degree of hyperthermia and the duration of hyperthermia matter. A patient who remains at 40.5 degrees Celsius for several hours may experience worse outcomes than a patient who briefly spikes to 42 degrees and is rapidly cooled. This is why every major resource emphasizes one principle. Cooling should begin immediately and should never wait for diagnostic confirmation.
Before we talk about the different hyperthermia syndromes, can we review how the body normally regulates temperature?
Definitely. Understanding normal thermoregulation helps explain why hyperthermia develops. Heat is generated primarily through metabolism and muscular activity. Heat is lost through four major mechanisms: radiation, convection, conduction, and evaporation. Under normal circumstances, radiation accounts for much of our heat loss. Convection transfers heat to moving air. Conduction transfers heat to cooler objects that come into contact with the skin, and evaporation removes heat through sweating. As environmental temperatures rise, radiation and convection become progressively less effective. Eventually, evaporation becomes the body's primary cooling mechanism. That's why humidity is such an important factor. Sweat only cools the body if it evaporates. In humid conditions, sweat may simply drip off the skin without evaporating effectively. The body continues generating heat, but its ability to dissipate heat becomes impaired, leading to progressive increases in core temperature.
So, what are the major causes of hyperthermia that clinicians should be thinking about?
A useful framework is to think of hypothermia as several different syndromes that all share a common endpoint. Broadly, the causes can be divided into environmental heat illness, exertional heat illness, drug-induced hypothermia, neurotransmitter syndromes such as serotonin syndrome and neuroleptic malignant syndrome, sympathomimetic toxicity, anticholinergic toxicity, endocrine emergencies like thyroid storm, neurologic causes involving hypothalamic dysfunction, and malignant hyperthermia. Although the underlying mechanisms differ, the initial management principles are remarkably consistent. Stabilize the patient, begin cooling immediately, identify the underlying syndrome, manage complications, and provide cause-specific treatment.
Let's say a patient arrives in the emergency department with a temperature of 41 degrees Celsius and altered mental status. What's our initial approach?
The initial approach should be exactly the same as for any critically ill patient. Start with airway, breathing, and circulation. Hyperthermic patients may be agitated, delirious, combative, seizing, or comatose. Determine whether airway protection is necessary. Assess breathing and oxygenation. Place the patient on continuous cardiac monitoring. Establish IV access. Check a blood glucose level and obtain a core temperature. At the same time, begin cooling immediately. This is one of the most important management pearls in hyperthermia. Cooling should not wait until laboratory studies are completed or until a specific diagnosis is established. The diagnosis and treatment occur simultaneously. Every minute of ongoing severe hyperthermia contributes to cellular injury.
You mentioned obtaining a core temperature. Why is that so important?
Because peripheral measurements can be very misleading. Axillary, temporal artery, and even oral temperatures may significantly underestimate the true core temperature in critically ill patients. The preferred methods are rectal, esophageal, bladder, or pulmonary artery temperature measurements. In most emergency settings, rectal temperature remains the standard. Failure to obtain an accurate core temperature can lead to under-recognition of severe hyperthermia and delays in treatment.
Let's talk about heat related illness first, since that's probably the most common cause.
That's a great place to start. Heat related illness exists on a spectrum. At the mild end are heat cramps, heat edema, heat rash, and heat syncope. More severe disease includes heat exhaustion and ultimately heat stroke. Heat cramps are painful involuntary muscle spasms that occur during or after exertion, often due to sodium depletion and dehydration. Management is straightforward and consists of rest, hydration, electrolyte replacement, and stretching. Heat syncope occurs when peripheral vasodilation and relative hypovolemia result in transient loss of consciousness. Patients typically improve with hydration, cooling, and supine positioning. Heat exhaustion represents significant physiologic stress from heat exposure but without central nervous system dysfunction. Patients often complain of weakness, fatigue, dizziness, headache, nausea, vomiting, and heavy sweating. They are typically tachycardic and volume depleted, but their mental status should remain relatively normal. Management includes removal from the hot environment, oral or IV hydration, electrolyte replacement, cooling measures, and observation.
And the presence of neurologic dysfunction is what pushes us into heat stroke?
Exactly. Heat stroke is defined by severe hypothermia accompanied by central nervous system dysfunction. That's the key distinction. Patients may present with confusion, delirium, ataxia, combativeness, seizures, or coma. If a patient with heat illness develops altered mental status, you should immediately be thinking about heat stroke. Heat stroke can be divided into classic heat stroke and exertional heat stroke. Classic heat stroke typically affects elderly patients, infants, and individuals with chronic medical conditions during environmental heat exposure. Exertional heat stroke occurs in athletes, military recruits, firefighters, and laborers engaged in intense physical activity. Importantly, exertional heat stroke often affects otherwise healthy young individuals.
What's actually happening physiologically during heat stroke?
Heat stroke is far more than an elevated temperature. It is essentially a systemic inflammatory syndrome. As temperatures rise, endothelial injury develops, inflammatory mediators are released, coagulation pathways become activated, and capillary leak occurs. The resulting physiology resembles severe sepsis and can rapidly progress to multi organ failure. Complications include rhabdomyolysis, acute kidney injury, hyperkalemia, hepatic failure, disseminated intravascular coagulation, acute respiratory distress syndrome, myocardial injury, seizures, and cerebral edema.
So let's talk about cooling. What's the best way to do it?
The goal is rapid cooling to approximately 38 to 39 degrees Celsius, after which active cooling should be stopped to avoid overshoot hypothermia. For exertional heat stroke, cold water immersion is considered the gold standard because it provides the fastest cooling rates. In sports medicine, you'll often hear the phrase cool first, transport second. When immersion isn't feasible, evaporative cooling is highly effective. Remove clothing, spray the patient with lukewarm water, and use large fans to promote evaporation. Ice packs can be applied to the groin, axillae, and neck. Cooling blankets and other external cooling devices may also be used. In severe cases, multiple cooling methods are often combined.
While cooling is underway, what laboratory evaluation should be obtained?
A broad workup is necessary because hyperthermia can injure nearly every organ system. Laboratory studies should include a CBC, comprehensive metabolic panel, creatine kinase level, liver enzymes, coagulation studies, fibrinogen, lactate, troponin, urinalysis, and blood gas analysis. Continuous ECG monitoring is also important because electrolyte abnormalities and myocardial injury can precipitate arrhythmias.
Let's move into some of the major hyperthermic toxidromes.
The first is serotonin syndrome, which results from excessive serotonergic activity. Common triggers include SSRIs, SNRIs, MAO inhibitors, linezolid, tramadol, dextromethorphan, fentanyl, MDMA, and combinations of serotonergic medications. The classic triad consists of altered mental status, autonomic instability, and neuromuscular hyperactivity. Patients are often agitated, hyperthermic, tachycardic, diaphoretic, hyperreflexic, and demonstrate inducible or spontaneous clonus. Clonus is one of the most important examination findings. Management begins with discontinuation of serotonergic medications. Aggressive benzodiazepine therapy reduces muscle activity and heat generation. IV fluids, active cooling, and supportive care are essential. Moderate to severe cases may benefit from cyproheptadine, and critically ill patients may require intubation and neuromuscular paralysis.
How does that differ from neuroleptic malignant syndrome?
Neuroleptic malignant syndrome, or NMS, usually develops more gradually over days rather than hours. It typically occurs after exposure to dopamine antagonists such as antipsychotic medications or after withdrawal of dopaminergic agents. The hallmark feature is severe generalized rigidity, often described as lead pipe rigidity. Patients also develop hyperthermia, autonomic instability, altered mental status, and markedly elevated creatine kinase levels. Management includes immediate discontinuation of the offending medication, aggressive hydration, cooling, supportive care, and treatment of complications. Bromocriptine is often used because it restores dopaminergic activity, and dantrolene may be considered in selected severe cases.
What about stimulant overdoses?
Sympathomimetic toxicity from cocaine, methamphetamine, amphetamines, synthetic cathinones, and MDMA is another important cause of hyperthermia. These patients often appear extremely agitated, hypertensive, tachycardic, and diaphoretic. The hyperthermia is driven largely by excessive muscular activity and adrenergic stimulation. The cornerstone of treatment is aggressive benzodiazepine sedation. Sedation decreases muscle activity and heat production. Physical restraints alone should generally be avoided because struggling against restraints can dramatically worsen hyperthermia and rhabdomyolysis.
And anticholinergic toxicity?
Anticholinergic toxicity presents differently because these patients are unable to sweat effectively. The classic description is hot as a hare, dry as a bone, red as a beet, blind as a bat, and mad as a hatter. Patients are hyperthermic, flushed, delirious, tachycardic, and have dry skin and mucous membranes. Cooling and supportive care remain the foundation of management.
Let's briefly touch on endocrine causes.
The most important endocrine cause is thyroid storm. These patients present with severe thyrotoxicosis, characterized by hyperthermia, tachycardia, atrial fibrillation, heart failure, agitation, delirium, and gastrointestinal symptoms. Treatment includes beta blockade, antithyroid medications, iodine, glucocorticoids, supportive care, and cooling measures. It's also important to avoid aspirin because it can increase free thyroid hormone levels.
Finally, let's talk about malignant hyperthermia.
Malignant hyperthermia is one of the most feared emergencies in anesthesiology. It is a pharmacogenetic disorder caused by abnormal calcium regulation within skeletal muscle, most commonly involving mutations of the ryanodine receptor. Exposure to volatile inhaled anesthetics or succinylcholine triggers uncontrolled calcium release, leading to sustained muscle contraction and a profound hypermetabolic state. One of the highest yield pearls is that hyperthermia is often a late finding. The earliest clue is frequently a rapidly rising end-tidal CO2. Patients develop tachycardia, muscle rigidity, hypercarbia, metabolic acidosis, hyperkalemia, rhabdomyolysis, and eventually severe hyperthermia. Management is immediate and aggressive. Triggering agents must be stopped. The patient should receive 100% oxygen and hyperventilation. Active cooling should begin, and complications such as hyperkalemia and acidosis must be treated. Most importantly, dantrolene should be administered immediately because it is the definitive treatment for malignant hyperthermia.
Before we finish, can you summarize the overall approach to hyperthermia?
Absolutely. Whenever you encounter a patient with severe hyperthermia, ask yourself 5 questions. First, is this truly hyperthermia rather than fever? Second, have I started active cooling immediately? Third, what syndrome is causing the hyperthermia? Fourth, what complications are developing? And fifth, what cause-specific treatments are required? The most important takeaway from this entire discussion is that hyperthermia is a medical emergency in which cooling and diagnosis occur simultaneously. Never delay cooling while searching for an answer. Whether you're dealing with heat stroke, serotonin syndrome, neuroleptic malignant syndrome, stimulant toxicity, thyroid storm, or malignant hyperthermia, rapid recognition, aggressive cooling, supportive care, and treatment of the underlying cause are what save lives.
So, in short, recognize it, cool it, identify the syndrome, treat complications, and address the underlying cause.